Good afternoon. Welcome to Conversation on Children's Health. My name is Mike Anderson. I am proud to serve as the president of UCSF Benioff Children's Hospitals, and it is just an honor to welcome you to this important forum. Conversations is our biannual lecture series which shares UCSF Benioff Children's Hospitals' unique expertise at taking care of kids, of taking care of the community, while really thanking our donors and welcoming new friends and new supporters. We couldn't do this alone. It always takes a village. In addition to the wonderful staff that work full-time at UCSF Benioff Children's Hospitals, I'd like to thank members of our host committee, and I ask them to stand individually, then we'll give you a big collective round of applause. Jackie Broad, Kirsten Brockman, Deborah Goldman, Anne Harper, and finally Gail Love. We're excited to be here in Marin County. We're excited of all the amazing things going on. We care for thousands and thousands of children every year from Marin County. And if some of you have read, and maybe some of you have been involved with our evolving relationship with Marin General Hospital as an entire UCSF system is really very important to us. How can we partner to continually bring the best care to our patients? How can we bring the benefits of an academic center such as research and teaching to care for patients across the Bay? So we at UCSF are incredibly proud of our growing and really, quite frankly, amazing relationship with Marin General. I'd also like to talk a little bit about why we're here today. As an intensive care doc, I must say that gut health, microbiome, microflora, had 0 classes on that in the 1990s, maybe 80s if you really are honest with me. I just sort of rounded up a little bit, I'm sorry. But our topic today, I think, shows an amazing evolution in medicine. That we are at really a Star Trek level when we think about the discoveries that we're making. And quite frankly, in the 1980s, you would have told me that the bacteria that are in your gut can be associated with disease. And more importantly, manipulating those individual bacteria can actually lead to healthier outcomes. I would have said that that was just either Star Trek or way too outside the norm. And yet there is science today that we're going to talk about and share with you that really UCSF is helping lead the way. I would like to acknowledge that we had invited Dr. Susan Lynch, who is an amazing researcher and clinician and literally an international expert in the microbiome. Unfortunately, Dr. Lynch had a family emergency that she needed to tend to. So one of my dear friends, an amazing physician, Michael Cabana, who I'll talk about a little bit more in just a moment, has agreed to step up. So thank you, Michael, very much for pinch hitting. So speaking of Michael Cabana, I have an 18-paragraph introduction. I will not read it all because he's an incredibly accomplished physician. He's a full professor of pediatrics, epidemiology, and biostatistics at UCSF, as well as a member of the core faculty in the Lee Institute for Health Policy at UCSF, and was just nominated to the U.S. Preventative Services Task Force at Health and Human Services. He is an accomplished clinician. His patients and families speak incredibly highly of him, but he is that unique flavor that is a UCSF doc, because he doesn't just stop at taking great care of patients. He also wants to leave this world better than he found it. So he's an incredibly productive researcher. His research focuses on the clinical management of asthma, epidemiology, and prevention. In particular, and obviously relevant for today, the use of probiotics as we take care of children. He's a principal investigator in a trial of infant probiotic supplements, as well as clinical trials focused on infant growth and colic. He is a member of more board of directors than I could read, including the International Scientific Association for Probiotic and Prebiotics. And as I said, he's also incredibly active clinically as well. So another round of applause for Dr. Cabana. And our moderator today, I introduced a couple of moments earlier, Anne Harper. Anne is a longtime supporter and advocate for us, our kids, our patients at UCSF Benioff Children's Hospitals. I'm sure, as all of you know, she produces a public radio show called City Visions, which is broadcast live each and every week on NPR affiliate KALW here in San Francisco. That's 91.7 on the FM dial. I have not been a disc jockey since the 1980s, and that felt really, really good. Her work in providing a public forum at KALW to explore many topics, including children's health, makes her really our perfect host for today. So please welcome me and join in our panel.
Thank you all for coming. It's so great to see such a great turnout. They asked me to say just a brief little snippet about why I got involved with UCSF Benioff Children's Hospitals, and that's kind of a mouthful, but I got involved when they were Children's Hospital Oakland. A friend of mine, Cassandra, who's a good friend of mine, asked me to help her out, and I think you've probably all been asked by a friend at some point to, probably some of you are experiencing that right now, or, learn about an organization, and so I wound up hosting an event, a preview party for them before their Notes and Words, their big benefit in April of every year. And if you have a chance to go to Notes and Words, go. It's an amazing event. But so I host this fundraiser, and I've hosted a bunch of fundraisers, and I enjoy doing that. But this one was really special. They brought a parent who had two very ill children, twins, who had been treated by Children's Hospital, and they got amazing care from the doctors there. They had a girl, a 16-year-old girl with a beautiful voice who had also been treated at that hospital. And there was something about that event. It was the combination of the storytelling and the music, and Gail Love was there, and Jackie Bra was there, and it was just really, I really got it. I really felt compelled by the work that they do, because really when you have a sick child, there's nothing else that matters, right, about the quality of their care and healing that child. And it also overlapped for me professionally, because I had been a litigator for an environmental nonprofit enforcing the Clean Air Act in the Central Valley, which has some of the worst air quality in the country. And I worked with kids. We actually went to Sacramento and helped some of these kids who were suffering from asthma to testify in the California legislature about how the air pollution affects their asthma. And back then it was easy to draw the line between air pollution exacerbating asthma. But what I didn't know then, which we do know now, is that there's actually a gut health connection too, between your gut health and asthma. And so this is really a pleasure for me to be here, because I really feel like it's kind of come full circle. There's been an amazing amount of research that's come out in the last 5 or 6 years about gut health, and I'm so pleased to have Dr. Michael Cabana here to talk about it. And so can you tell us a little bit about your work and about your research, and why you're in the field that you're in?
Sure. I'm a general pediatrician, and whoever organized this event, thank you. I live in Mill Valley, so this is the shortest commute that I've ever had, and if you want to move my offices here, that would be good. So I'm trained as a general pediatrician. I see a lot of kids with asthma, so my area of research was really the prevention of asthma. So we were trying to prevent exacerbations, prevent kids from going to the emergency room with asthma flare-ups. But as a general pediatrician, I wanted to go one step further. Is there something we could do to prevent kids from even developing asthma? And that's how I became interested in probiotics. There was a paper that came out in 2001 from a group in Finland which suggested that if you give a probiotic, you can potentially prevent the development of allergic disease. So I thought that was a really interesting thought, and that's what led me to this area. But it was the idea of prevention, keeping those kids out of the emergency room and making sure those emergency doctors went out of business.
So give us, there's probably a wide range of expertise here or knowledge about the microbiome. Can you talk about what the microbiome is and why we should care about it?
Sure. I graduated from medical school around the same time as you did, Mike, but it really wasn't discussed. This is something that's really developed in the last 10 years or so. The microbiota refers to the bacteria in your body and on your body. So we talk about the microbiota in certain parts of your body. So there's a skin microbiota, the gut microbiota, the urinary tract microbiota as well too. So that's microbiota. And then microbiome refers to the genetic capabilities or the genome of the bacteria in your body. Now to put this in perspective, the number of cells that you have is 10 to the 13, so 10 trillion cells. The number of bacteria in your body, 10 to the 14. So for every one cell that you have, there's 10 bacteria. You're basically a bus for bacteria, moving stuff around. So they outnumber you, and it does make a big difference if you consider how much bacteria there are. If you look in the gut, about 2 kilograms of bacteria. It's probably not appropriate for lunchtime. Wash your hands. So Mike, it's as if we went through medical school and they forgot to teach us about a whole organ system.
Right.
So really, in the next few years, when we rewrite textbooks in medicine, there probably is going to be a big chapter on the microbiome and what it does.
And the microbiome changes over time, right? I mean, and the different exposures to germs. I mean, so I have 3 teenagers. The first time, you know, my oldest son dropped his pacifier, you know, I sterilized it before I put it back in his mouth, you know. And with the second child, I probably washed it underwater, you know. The third child, I was just like, you know, here. I mean, so you expose kids to germs, right? And is it something you should be worried about, or is it something that's a good thing?
Yeah, that's a great question. So your microbiome does change over time. When you're born, there's a certain characteristic microbiome, and we can talk about that as well. It changes depending on how your mother decides or parents decide to feed you. And when you start transitioning to adult food, by about 1 year of age or 2 years of age is when you start developing a grown or adult microbiome. Now, the idea of siblings, now this is really interesting. So in 1989, this paper, a guy named David Strawn publishes this paper and looks at the prevalence of allergies. If you're the oldest, you're more likely to have allergies. If you're the second oldest in your family, a little bit less likely. Third oldest, a lot less likely. So there's this dose response. The more big brothers and sisters you have, you seem to be less likely to have allergies. So he postulated that it's these older siblings who are running around with colds and snot and whatever, who are probably not potty trained. So you're getting exposed to a lot of bacteria. So he makes the jump that being exposed to potential infectious diseases can protect you. So I think you should still probably rinse the pacifier. But if you forget to, or your kid picks it up before you do and puts it in his or her mouth, it's probably not too bad.
Probably okay. And pets too? Do pets make a difference?
Pets, so interesting study by Doug Owenby, published in 2003. So here's the other interesting thing. Some parents have told me, I'm getting a dog to get rid of my child's asthma. And you think, oh, that doesn't quite make sense. But then you read studies by Doug Owenby that suggest that actually having pets makes a difference. And there's this thing we look for called a dose response. If 1 pet is good, is 2 pets better? Is 3 pets even better? So 3 dogs are better than 2 dogs, which are better than 1 dog. And dogs are slightly better than cats. But having a pet seems to protect you from the development of asthma and allergies.
Really interesting. Yeah. And does it depend when you have the pet? Do you need to have the pet?
So before you go out and buy So I am a professor of biostatistics and epidemiology. These are observational studies. These are not randomized controlled trials. So what could happen is that if you're an allergic family, like the Cabana family, we have no dogs. So maybe that's why we're seeing this. But it is interesting to see that. And it's also the timing that makes a difference. If you are going to get a dog early in your child's life, so in the first few months. If your child has already developed asthma or allergies, getting a cat or a dog then might exacerbate it. So it's really the timing that makes a difference too. So pets can be protective or have been shown to be protective in observational studies. And if you're going to do that, do it early in a child's life.
Okay. And can you talk a little bit about how children are born and how that can affect their microbiome?
Sure. So one of the things that really should be a quality metric is how often a hospital does a C-section. It actually turns out that having a C-section puts you at greater risk for developing allergic disease later in life. So if you had a choice between a vaginal, so I'm not going to, so we've already had our kids, but if you had a choice between a vaginal delivery and a C-section, a vaginal delivery seems to be protective for developing asthma and allergies. And we can talk about that more too.
Okay, because of the biota that they're exposed to?
Yeah, so what's happening in the third trimester is a woman's gut microbiota is changing because of the changes in pregnancy. So the types of bacteria that are thriving in a woman's gut are changing. It's probably colonizing the vaginal tract as well too. So in a way, it's kind of preparing the child for being born. And there probably is a reason. There's probably a reason why God had us born face first, born through our mother's vaginas, basically, which is colonized by your mother's stool. So there probably is a reason for that, and it seems to be protective.
Oh, ironically, it's a good thing that they're exposed to all those germs.
It's a good thing. If you look at the, this is a really interesting lunchtime time. If you look at babies born via C-section, the types of bacteria that they're colonized with tends to be staph. So Staphylococcus, which is found in the skin, and that makes sense. If you look at babies that are born vaginally, it tends to be lactobacillus as well. So that's that first imprinting that occurs of the child's gut, what the child's exposed to in the birth canal. The other big thing that you can do is also breastfeed. Mm-hmm. So I do a lot of work with probiotics, and there's another concept called prebiotics. Prebiotics are substances that help beneficial bacteria grow. Human milk contains human milk oligosaccharides, which are basically a prebiotic, and they tend to help certain bacteria grow and thrive. And these are bacteria called bifidobacteria. So that's why babies who are breastfed tend to be colonized with this bacteria, bifidobacteria. So
that's protective as well.
Very protective. If you have high levels of bifidobacteria, less likely to develop asthma later on in life. High levels of Clostridia, increased chance of developing asthma later in life. So it's really interesting. It's the exposure and the timing of the exposure that makes a difference.
Okay. And what about when kids get a little bit older and they get ear infections and they go on antibiotics? What effect does that have on their microbiome?
Yeah, so it's probably too late at that point in terms of an effect of allergic disease. But in terms of maintaining gut health and a diverse microbiota, the more times you expose your gut to antibiotics, it really disrupts this the system or your microbiota, and it becomes less resilient. So one course of antibiotics is probably not too bad, but repeated courses over a long period of time, you tend to see less diversity occurring in your microbiota, and the body becomes less resistant or resilient to changes as well too.
So what can you do? Do probiotics help in that regard?
Well, the problem with probiotics is, although they have a beneficial effect, they tend not to colonize long term. So you'd have to take those over long periods of time. The best thing to do is probably have a balanced diet to allow a variety of bacteria to grow back. And that's probably the best advice there. For specific situations, and we can talk about that, you might want to have specific probiotic strains used as well too.
Okay, so how do you know what probiotic to use? So say, my daughter actually right now is on an antibiotic. She has strep throat. So how would I begin to figure out what probiotic to give her? And should I give it while she's getting the antibiotic or afterwards? Or how do you figure that out?
So probiotics, according to the World Health Organization, are defined as live microorganisms when given in adequate amounts that confer a health benefit. So if your kids go to park school and they ask you about oxymorons, like jumbo shrimp, ineffective probiotic, throw that one back at your third grade teacher. So there's no such thing as an ineffective probiotic by definition because they have to be effective. The unfortunate thing is the term probiotic can be marketed liberally in the United States, so it's thrown on to just about everything. So by definition, it should have a beneficial effect, but a lot of things are labeled probiotics. So I think working with your healthcare provider to find the best probiotic that makes a difference And for antibiotic-associated diarrhea, there is good evidence that probiotic strains do make a difference. For parents that are really motivated, there's 1 or 2 probiotics that I recommend that the child should take while the child is taking an antibiotic.
Oh, really? Okay. Can you tell us what those are? So write this down.
Yeah. LG. So it's not a CME event, right? So LGG, Lactobacillus GG. So done by Cultural. We've used that in clinical trials. Lactobacillus reuteri, which is sold by BioGaia, is also very effective. And then remember the definition. I said live microorganisms. I didn't say live bacteria. And that's because fungi can also be used. Saccharomyces boulardii. So there's 3 companies that manufacture that. Probiotic can also be used. So Saccharomyces boulardii, LGG, L. reuteri, and there's specific strains that make a difference.
So you ask your doctor, or you go to Whole Foods, or where do you come by these probiotics?
I like to make sure that there's a study that backs it up. So there's a very good article by Dr. Hempel, which is published in JAMA, that lists all the probiotics that have been proven effective.
Oh, nice.
The International Scientific Association of Probiotics and Prebiotics also has a website, which is also a resource as well. So ISAP is another place to go to.
Good. So what other kinds of things affect the health of your microbiome? Obviously antibiotics is one, but what are other things that can influence it?
Sure. So we talked about birth. We talked about breastfeeding, antibiotics, buying a pet. Living in a rural community actually seems to be helpful too.
Farm animals.
Farm animals. Famous study by Rydell. And Rydell looked at how close you were in a farm to a cow. So in Bavaria, they had families that lived next to the barn, or on top of the barn, or away from the barn. And the closer you were to the cows, so if you're basically living on top of the barn with the cows underneath, you're much less likely to have allergic disease as well too. So it's probably exposure to large animals. So probably can't buy a cow in Mill Valley and move it into your house, but that seems to be healthy.
Okay. And what about diet and sugar, or what other specific things that you eat that help or don't help your microbiome?
So prebiotics tend to help probiotics, and prebiotics tend to overlap with fiber. So in general, a high fiber diet can also be effective as well too. There are fermented foods that also have live bacteria that can also increase your diversity as well. So sauerkraut, kimchi, those types of foods can also help. But in general, a balanced diet that's high in fiber can be a way to increase the diversity in probiotics as well too. Okay,
good. So are there other things that we can do to improve the health of our microbiomes, or?
I think there's a lot to figure out in terms of what makes a difference. I think what we're learning is that it's not just diet and a clinical outcome, but it's what you're eating, how that's interacting with your microbiota, and what's being produced that's leading to specific outcomes as well too. So that's why it's nice to work with Sue Lynch, because we have a lot of samples that we can send to her lab, and we can try and figure out those steps in between.
Can you talk a little bit about her research? I know she did some fascinating, she analyzed babies' stool, and she was able to sort of predict certain outcomes with allergies and asthma based on that stool. Is that right?
Yeah, so there were certain observations about certain exposures that led to certain outcomes. And then we figured out that, no, maybe it's the bacteria. And then the big change that happened was about 10 years ago. Instead of having to culture the bacteria one by one, we could actually find the fragments of their DNA and figure out which bacteria were there. So all of a sudden we had lots of information on which bacteria were there. So that's the microbiota, then the microbiome, and then what the bacteria produce, so the metabolites of that. So what Sue has found, working with colleagues in Detroit, is that a specific compound that's produced by bacteria, it's called 12,13-dihome. It's a much longer word. But that tends to affect how your immune system reacts to different allergens. And when that specific chemical is elevated, and we can find that in stool, it tends to predict an increased risk of asthma and allergic disease. So when Sue found that out, she knew that I was working on the TIP study, so she came back to me and said, you know that stool you have in your freezer?
Not at home.
Not at home. Do you mind if we take a look at that and just validate this? And she looked for that specific signature as well, and it actually had very good sensitivity and specificity at predicting which kids might later develop asthma in our cohort as well too. So it's exciting to know that there might be a marker that we can look for that might predict the later development of asthma, because we really don't have anything like that right now.
And then it could be an intervention, presumably.
Yeah, so then it's how to get rid of this 12-13 dihome, this chemical that's being produced in the gut. And maybe that's why some of these probiotic interventions work or don't work, because if it changes the microbiome, maybe it can change the types of chemicals or metabolites that are being produced.
And there's some work on colic too, right? Treating babies with probiotics for colic?
Yeah, did anyone ever have a baby with colic? Yeah. It's usually about 25% of the population. There you go. Okay. So there's nothing we can do for kids with colic. If I see a patient with colic in my clinic, I know that's a good 30 minutes going through all the things to reassure parents. It tends to pass by the time kids are 4 months of age, but it can be very disruptive. So there's a specific probiotic, Lactobacillus reuteri, DSM 17938. So it's a very, very specific strain. And remember, the strains make a difference that seems to decrease crying times in kids. It was 95% effective in an Italian study, reproduced in Poland, also reproduced in Canada. By the time we tried to do the study in the United States, I couldn't get parents to be in the control group because they already knew it was effective. So that's a very, very interesting probiotic. It seems like it affects a specific receptor in the gut called TRPV1. Mm-hmm. It's a capsaicin receptor. Has anyone ever had a red hot chili pepper? So capsaicin is what makes the red hot chili pepper red hot. So it seems to block that. So that's another way we're learning that the microbiome and what you're exposed to can affect other manifestations of disease.
Nice. So are there other exciting things coming down the pike that we should be on the lookout for? What areas of research are really hot right now?
Sure. I think finding this, what's called the gut-brain axis, how the metabolites that are produced in the gut affect the metabolism of something called tryptophan, which is used to make serotonin, which affects your mood or depression. So the gut-brain axis, we didn't learn that one in medical school, did we? But I think those are the
So your mental health can depend on your gut health in that sense.
In some ways, yeah.
Interesting. All right, great. Well, I think we're ready for questions if you all have any for Dr. Cabana. Yes?
As I buttered my third piece of bread.
There's a microphone kind of coming to you. Yeah. I think.
You know, there's not for people that are necessarily gluten intolerant, but there's, I think, a general belief, in society, especially here in the Bay Area, people have a heightened awareness of the effect of gluten on the body, not just for kids, but for adults. Can you speak to that a little bit? I mean, I think for most of us in the room growing up, we all ate gluten all the time. Me as an exception, I think everyone here turned out okay. So any comments would be welcome.
Yeah, I think we're recognizing the role of gluten more. It's not a specific area of research that I do, so yeah, I can't comment too much specifically. There's probably an interaction with how it's affecting how it's interacting with the gut microbiome as well too, but it's something that we're recognizing more, but it's not really one of my areas that I do a lot of work in.
Could you talk about the effects of inflammation on the gut, how that affects the microbiome?
Sure. Well, it's more that the microbiome, in terms of the chemicals that it's producing or the metabolites it's producing, can be pro-inflammatory and can rev up the immune system or decrease the immune system, decrease what can suppress the immune system as well too. So the 12-13 dihome actually helps with T regulatory cells, which kind of puts the brakes on the immune system from going too far. So
can you explain a little bit about how your gut controls your immune system, or the effect your gut has on the immune system?
I think there's many different theories. If you think of your immune system as a car driving around and looking for bad things to, I guess, run over. There's T cells and B cells. That's the accelerator, and T regulatory cells are the brake. So if your body sees something it doesn't like, it's ready to run over that antigen or that allergen. But what happens is, let's say it's a peanut, and your body likes peanuts, and you don't want to have an allergic reaction to peanuts. It's your T regulatory cells that shut that down. So when you have 12, 13 dihome, high levels of that, it suppresses your brakes, so it just tends to go crazy, and you tend to overreact to these allergies. So it dysregulates a very tightly regulated system that tends to, so you tend to overreact as well too.
Okay, and there's been lots of progress on dealing with allergies like that as well.
Yeah, there is, and we've changed our approach to certain things as well too.
Right, that exposure is actually a good thing.
It can be a good thing, so yeah, the timing of exposure makes a difference. So the issue with peanuts is a little bit different. So starting in 2015, if there's a child that has an egg allergy and eczema, pediatricians are now recommending that these kids get exposed early to peanuts between 5 and 11 months of age. So when we were in residency, no peanuts till a child was after 1. So it's slightly different also because it's thought that if you have eczema and you get exposed to peanuts through your skin, it's much worse than getting exposed to peanuts through your gut, so you don't develop that tolerance. So, so it's the timing, what you're exposed to, and it turns out how you're exposed if it's through the skin, like with eczema where that's broken down versus the gut. So much better to get it through the gut for that population of kids.
Can you talk a little bit about that study in Israel that was done with kids who were eating a peanut product early?
Yeah, I think it's more of an epidemiologic study.
Overview,
it's called BAMBA. I'm going to call it, so Bamba. I should have bought stock. So it's a puffed peanut pastry or puffed peanut product, which is what I understand. And I guess kids in Israel tend to eat this product, and the levels of peanut allergies are much, much lower. So it's what you're exposed to and then how it's prepared, it seems to make a difference as well, too.
Just for the record, no peanuts to young babies because of the airway issues. The intensive care doc got a little nervous there for a second. Sorry.
So we give it as peanut butter.
Thank you very much. I feel better.
Thank you for clarifying that.
A really wonderful panel discussion. Michael, you took a very complex topic and really simplified it wonderfully. Back to the antibiotic issue, because I know RSV and flu season is here, coming around the corner. You mentioned the deleterious effects of being exposed either to prolonged antibiotics or multiple courses. I know that sometimes a source of tension between pediatricians and families is should my child be on a Z-Pak or a MOX, and I think sometimes once again that can be a source of tension. Do you want to describe how you approach that topic, because I think it's timely?
Sure. So when a child has an infection, what I'm trying to figure out is whether it's a viral infection or a bacterial infection. And if I were a betting person, most of the time it's viral. So what I'm trying to do is find that one child out of 15 or 20 that might have a bacterial infection that needs an antibiotic. So I actually make sure I look in the ears and we insufflate, check the throat, listen to the lungs very carefully. And if there's no sign of any infection in any of those areas where bacteria can hide, I'm probably just going to watch and wait. Most viruses last about 3 to 5 days, but adenovirus can last 14 days. So for the first 3 to 5 days, your child might be very uncomfortable, and there's ways you can treat that, but I usually try and avoid giving antibiotics. And even if it's an ear infection, usually in about 24 hours, it'll figure out a way to drain on its own through the eustachian tube. So I usually tell parents, wait 24 hours, let's see if we can get by without that. So if you're a bridge player, there's a technique called finessing, and that's when you don't use your high card, you use a slightly lower card. So you don't use your king, you use your jack. So it's actually good to try and finesse. Save the big guns, save your ace for when you really need it. And that can be a source of tension as well too, in terms of whether or not to start antibiotics. But usually a good clinician can pick that up. And you just want a thorough history and a thorough physical exam. Oh, here's the other thing. If it's the whole family that's sick, it's probably a cold. So usually if the whole family comes to the emergency room, it usually starts with C. It's usually colds, car accidents, and carbon monoxide is the mnemonic only. So if there's other memories of other members of the family that are sick, it's probably viral.
Okay. All right, good. Yes.
Yeah. Let's see, this is a specific question. Have you seen any research about the correlation between the gut and eosinophilactic esophagitis?
Yes, okay, so eosinophils are a specific cell that tend to be elevated with allergies. So I would probably refer you to Sue Rhee, our director of pediatric gastroenterology, because they have a specific clinic on eosinophilic esophagitis for that. So I haven't done a lot of work in that area, and usually if we're concerned with that specific disease, I'm referring to a pediatric gastroenterologist because it might require some special testing.
Yeah.
Oh, sorry. Thank you for the presentation. It was really interesting. I'm wondering, you mentioned a lot of studies where exposure to pets or to certain probiotics or foods make a big impact at early stages in life. Do you think that that's because those at that early stage in life, they're having a lasting impact on the patient's immune system, or is that because only at that stage in life can those probiotics engraft permanently in their gut and stay with them as they grow older? And if that's the answer, is there any way that you've been experimenting with to successfully engraft probiotics or specific strains into older patients?
Yeah, so it's probably the second part. There's a window of opportunity to affect making changes. So there's two types of there's two phenotypes or two cells. There's Th1 and Th2. So I'll give the whole hygiene hypothesis in 3 points. Th1 and Th2. Th1 is associated with infection. Th2 is associated with later development of allergy. So there's two arms. When you're born, the default is Th2. And then the theory is that sometime in the first 3 months or 6 months of life, you get exposed to some sort of infection or some infectious exposure, and you switch from T1 to T2, or excuse me, T2 to T1. If you don't have that exposure early on, you're stuck in Th2, which is associated with allergies. So that's why, that's the idea of this hygiene hypothesis, that if you're too clean, you don't have a lot of exposures in the first year of life, you're stuck on that allergic pathway. So it's probably a window of opportunity, because after 1 year, it definitely doesn't make a difference if you're exposed. You just get sick. And then the other thing with probiotics is probiotics don't colonize. You have to keep giving it over and over again. So the best way to prevent, I think, is to intervene early and intervene during that window. Some folks even think it's during the 3rd trimester of a woman's pregnancy that you want to intervene. So it might be the obstetricians that need to be doing this as well, too.
I had a question. Do you have any research or information on long-term antibiotic use and autoimmune deficiencies developed in children?
Yeah, so not personally, but we have seen a rise in autoimmune diseases, and it's kind of associated with the hygiene hypothesis as well too. That is, as we move to more of a modern urban setting, we've seen more of these autoimmune diseases, but it's not a specific area of research that I work on or do.
But you think there might be an association?
From observational studies, it seems like there is that association as well too.
Okay.
First, for the woman who asked about EOE, I just want to tell you that I just went through something with my daughter where she was rushed to UCSF Benioff Children's Hospital, and it's one of the reasons I'm here today, because that clinic is fantastic. So I don't know how far along you are in that, but I highly recommend you speak with someone directly there. But my question is, there was a book published earlier this year by 2 doctors in Marin County, and I can't remember the name, I apologize. And the book was filled with allegorical information about the effects of GMOs and glyphosates and cleaning products and all kinds of things on the microbiome. And what I wondered is how much actual scientific evidence is there that's looking at that relationship?
In terms of those specific
Ill
products?
effects. Well, the idea was they were seeing an increased number of children with, you name it, anything from a migraine, asthma, and they were, they had determined that it had to do with things in their environment, but primarily it was glyphosates, cleaning products, and GMOs. And one of their big recommendations was to eat organic. And that turns into a whole fiery other debate and conversation. But what I did wonder is there any actual scientific evidence that's trying to determine if GMOs are bad for the microbiome, if organic food really is better for the microbiome, you know, or are we just going to be left with this allegorical information?
Yeah, I haven't done a lot of specific research on specific chemicals or specific exposures. The use of cleaners, though, extensive use of cleaners, you talked about dropping that pacifier.
Yeah.
It might not be a bad thing. And the other thing with the association with pets, it actually makes a difference about what type of pet it is. So I talked about dogs being good, but it's dogs that actually spend time outdoors, and they probably bring something from the outdoor environment into your house. So when Sue Lynch collaborated with folks in Detroit, they're actually taking dust samples, or standardized dust samples of what was on the floor in specific houses. So I can see the link with overuse of cleaning products may be affecting that as well, but I'm not sure about those specific chemicals. So buy a dog.
Okay.
And a cow.
Yes.
And a cow.
Jackie.
Yes.
Thank you. Two quick things. You mentioned most patients possibly coming in not feeling well being a viral situation where you wait and see and don't prescribe antibiotics. I also read recently about cough suppressants and cough syrups. Same exact thing where patients are complaining of coughing, sore throat, and there's been studies done now that they're equating just resting and having fluids as being equivalent to, an over-the-counter cough syrup. I don't know if you read the same.
Yeah, specifically cough medicines with codeine, bad thing. Not recommended at all. The other thing is, when I ask about coughing, here's the pearl. Is your child coughing when your child's sitting up or when they're lying down at night? If it's a cough from lying down at night, it's probably that postnasal drip that you get in the sinuses that's dripping down, causing you to cough. I would not want to suppress that. I would want to kind of cough it up and get it out of there. So I usually avoid recommending cough suppressants for kids, and especially cough suppressants with codeine.
With codeine.
Yeah.
And the other quick thing was you mentioned in utero what the mother possibly her diet is. And there seems to be a common sense theme that you're bringing up about moderation and eating a balanced diet, because I remember having tons of peanut butter as a pregnant, soon-to-be mother, and being petrified when these studies started coming out that, you should watch what you eat when you're pregnant. Now it's going back to moderation and exposing the fetus might be a good thing. Is that right?
Yeah, so it's okay to eat peanut butter during pregnancy, so go ahead, keep doing that. Probably not a good idea to drink a lot of beer, but
Besides alcohol.
but peanut butter is fine. So everything in moderation. That being said, when we work with kids, and I think if you talk to our adult colleagues, they probably have more experience with other more extreme diets, like the ketogenic diet or the paleo diet. So there's not a lot of research in kids because usually we try it out in adults first. So in general, that's the usual advice I give for kids. Usually everything in moderation. Watch the food pyramid, which has a base of a high fiber diet, which tends to be very good for kids.
Dr. Cabana, I have a question. Living in Marin, kombucha is a popular drink, and I've been spending lots of money and drinking it daily. Is there any science to back up the benefits of kombucha, because it's touted as having all these probiotics that help your
Yeah, so kombucha fermented drink it's a fermented drink. That's my understanding. Yeah, so it's probably got some bacteria there, live bacteria. I'm not familiar with the literature on kombucha. I'm sure somebody's done a meta-analysis on that as well too, but I'm not familiar. But it's probably not a bad thing, and I haven't heard of anything bad with it. But fermented foods, that's probably not bad for your diet.
So I'm wondering if you can help correct a probably inaccurate family legend that started with my father, who was a colicky baby who grew up on a dairy farm, and my grandmother swears that the colic stopped immediately because she stopped breastfeeding and switched him to cow's milk, which was probably unpasteurized coming right off the farm. And maybe it wasn't just the benefits of dairy that stopped his colic, but maybe it was bacterial related.
Like cow, yeah. You see the cow. So what I've after doing a lot of work at UCSF, my thought is that you can disagree with the logic, but you can't deny the observation. So something happened. There's lots of potential explanations for that, including maybe, was it your father? Yeah, maybe he was turning 4 months. So in general, it peaks at 6 weeks of life and it goes down. We're actually doing a study now where we're recruiting mothers to keep recorders, voice-activated recorders near their babies to see when that actually peaks. And it's about 6 weeks. So it could be true, and unrelated. So you can disagree with the logic, but you can't deny the observation. That's the best way to say it.
So I read recently, I can't remember where I read it, but this statement that probiotics are useless without prebiotics.
There's very good colic, antibiotic-associated diarrhea, treatment of certain gastrointestinal infections. Very good studies that show that probiotics by themselves are fine. Sometimes probiotics are packaged with a prebiotic, and it's called a symbiotic, so it can't hurt. But there are many good studies with probiotics alone that are fine. So.
Good. One more, two more.
Okay. Does the research into the microbiome, will that lead to any changes in the use of steroids in the treatment of asthma symptoms?
Okay, so use of steroids for asthma symptoms. If a child is having a lot of trouble breathing, you probably need to give high-dose systemic steroids to prevent the inflammation. For kids who have kind of chronic symptoms, more than twice a week or 2 times per month at night, probably a low dose of a steroid or an inhaled steroid is probably useful. So the question you bring up is, what's the long-term effect on the microbiome if we're giving steroids? So there is work looking at what the long-term effect is on the airway microbiome and on the gut microbiome in terms of giving these steroids as well too. So Homer Boucher, who's also at UCSF, is working on that question. But it's probably also not a good idea to give steroids for long periods of time. 1 or 2 bursts per year is probably okay, but there's probably some long-term effect also on at least the upper airway and the esophageal microbiome.
Hi, I had 2 questions really quick. One, because there's microbiome on our skin, and there's lots of studies about the benefits of sauna on your health. So is that actually harmful to the microbiome on your skin? My second question, can you give us specific recommendations in how to restore the biodiversity of a microbiome if you grew up as a child taking lots of antibiotics? I mean, there must be steps one can take, right?
Yeah. So there's 2 parts to your question. One is about the skin microbiota, and I'm not an expert in that, so I'm going to have to pass on that, defer to my dermatology colleagues. In terms of restoring your microbiota, avoid antibiotics, eat a balanced diet. For kids who have chronic symptoms like chronic C. difficile infections, there are drastic therapies like fecal transplantation. So that's been used as well too, but not something we want to do, not something you want to do frequently as well either. So, but those are some, so eating a balanced diet, avoiding antibiotics, probably using probiotics potentially, or certain strains, and then there's some extreme things that you can do for kids who have extreme situations.
Okay, one more question. Yeah, Kathy.
I understand what you said about the impact of the microbiome on the development of allergies. I'm curious about future prospects for any use of the microbiome for kids who already have allergies. Is there, and because you talked about the research, and most of what I understand the research on allergies has to do with gradual desensitization. So what is the relationship between the microbiome and the kind of future prospects for kids who have life-threatening food allergies?
Yeah, that's an area. So the work that I've done is primarily in prevention. I don't know if there's much that you can do right now. I don't think there's much that you can do once the immune system has already been switched or is stuck in this Th2 pattern. So I don't know the answer to that question, but what's promising seems to be prevention, and there are several studies that suggest that early interventions might make a difference. But for kids who already have asthma or allergic disease, trying to turn that off, I think there's a lot of work that still needs to be done. It's a good area of research.
All right. Thank you all so much for coming. We have Gail Love, who is a long-term supporter of Children's Hospitals, who's going to give some closing remarks. So thank you.
I'm glad to hear about the codeine cough syrup now that my son's 16, because that stuff saved my life for many of winters, and now I was like, oh, oops. Anyway, I just wanted to say again a quick thank you to Dr. Cabana and Anne for the really interesting conversation. And it's also just another aspect of what UCSF Children's Hospital in Oakland is doing. You know, I was a guest at one of Anne's events, and that's how I got involved about 6 or so years ago. And I just knew, living in Marin, that Children's was the level 1 trauma center that our kids were helicoptered to in the case of an emergency. And that was my extent of knowledge. Getting more involved, going to see the hospital and hearing about all the different research that's going on in different specialties really, really opened my eyes. It is an amazing hospital. They have fantastic doctors. They have, I'm a speech language pathologist. They have one of the best rehab centers in the area. And I, especially kind of like to tout that. They also have the Center for Child Protection, which is one of the only specialized units that treat and diagnose child abuse. And imagine being a pediatrician that specializes in that. He is one of my heroes, Dr. Crawford Jeff Hubeck. He's amazing, and he gives a lot back to the community and outreach programs. So that's, again, just one other small area of what this hospital does and why I support it. So I want to say thanks again to my co-host, and thank you to all of you for being here, and hope you enjoy the rest of your afternoon.